Assalamu alaikum. Today we'll talk about bronchial asthma. We will go through these topics: the definition, epidemiology, risk factors, pathology and pathogenesis, diagnosis, and management. The definition of asthma. Asthma is a heterogeneous disease. In a minute, we will discuss or talk about different phenotypes of asthma, and usually characterized by chronic airway inflammation. Clinically, these patients present with chronic respiratory symptoms, cough, shortness of breath, and wheeze, and these symptoms vary over time and in intensity, and there is associated variable expiratory airflow limitation. Asthma is usually associated with airway inflammation and airway hyperresponsiveness, but these are not enough or necessary to make the diagnosis. In the coming slides, we will discuss what we mean by airway inflammation, what's the airway hyperresponsiveness, as well as the variable airflow obstruction. There are different phenotypes of asthma. The most common and easily understood is probably the allergic asthma or eosinophilic. If we examine the sputum after sputum induction, we found a lot of eosinophils in the sputum. This type of asthma usually happens in atopic persons. Usually they have family history of atopic diseases like asthma, eczema, and rhinitis. Usually started in early childhood and very responsive to inhaled corticosteroids. The other phenotype is the non-allergic asthma, where the sputum induction showed very few neutrophils or eosinophils or little granulocytes, and usually they require higher doses of inhaled corticosteroids to control the disease. And we have late onset asthma, which usually started in adulthood, more common in females, and again, they require higher doses of inhaled corticosteroids and sometimes refractory to inhaled corticosteroids. Another phenotype of asthma, those who have asthma and fixed airflow limitation. The fixed airflow limitation is characteristically found in COPD patients, but some patients with asthma, if they are not treated properly, that will lead to airway remodeling and fixed airway obstruction similar to that seen in COPD. And another phenotype, asthma with obesity. Usually they have little eosinophilic inflammation. They require higher doses of inhaled corticosteroids, but if the patients lose weight, their asthma might come under control easily with the inhaled corticosteroids. The epidemiology, asthma is a very common disease, about 300 million cases all around the world. The prevalence of asthma varies in different countries. Many studies in children show that the prevalence varies between 1 and 18%. It causes a significant number of preventable deaths, but they are much lower than those of COPD. And these deaths can be prevented if we treat asthma properly, but it is a cause of major absence from school and workplace. The healthcare expenditure on asthma is very high. In this map, as you can see, this is the prevalence of asthma in children in various countries. Those in black are the countries with the highest prevalence, more than 10%. In Jordan, we are in the blue area, and the prevalence is around between 5 and 9%. What are the risk factors for asthma? We have host factors and we have environmental factors. With the host factors, we have genetic factors. Asthma is not a disease that is transmitted by a single gene, but it is polygenic. Some genes are involved in the pathogenesis and others are involved in the response to treatment. The other risk factor is atopy. Atopy means overproduction of IgE and exposure to common aeroallergens like house dust mite, tree pollens, and so on. We can check whether the person is atopic or not by either measuring specific IgE levels in the blood or by doing skin test. The other risk factor is airway hyperresponsiveness. All asthmatics, they have airway hyperresponsiveness, but not all persons who have airway hyperresponsiveness are asthmatic. What we mean by airway hyperresponsiveness means that the asthmatic airways, they do constrict to non-specific stimuli. If we expose them to inhaled or nebulized histamine or methacholine, the FEV1 will drop by more than 20%. FEV1 is the forced expiratory volume in the first second of vital capacity maneuver. The FEV1 will drop by more than 20% on exposure to concentration of histamine or methacholine less than 8 mg per ml. Because above 8 mg, even normal airways, they do constrict. The other risk factor is the lung function in infancy, and this depends on, for example, the birth weight of the baby, whether he is premature or severe respiratory illnesses in infancy. These infants are more likely to develop asthma later on. Also, the gender of the child also is important. It is known that asthma is more prevalent in boys during childhood rather than girls, and this is probably related to the caliber of the airways. As girls, they have wider caliber of airways. This is probably related to the estrogen and sex hormones. Obesity is a risk factor for asthma, and also obese persons, if they develop asthma, their asthma is difficult to control unless they lose weight. Rhinitis is a risk factor for asthma. About 40% of patients who have rhinitis, they have associated bronchial asthma. About the environmental factors, allergens, whether indoor or outdoor allergens, the most common indoor allergen is probably the house dust mite, the cockroach droplets, and the outdoor allergens like tree pollens, grass pollens, animal danders, and animal furs. Infections, especially in infancy and childhood, respiratory syncytial virus, parainfluenza virus, or rhinovirus, they are associated with asthma. Occupational sensitizers, this is important in any adult who has asthma. We have to take a detailed occupational history because various chemicals might induce asthma. Tobacco smoking is a risk factor for bronchial asthma, as well as air pollution, and it is estimated that about 13% of the global asthma incidence in children may be attributed to traffic-related air pollution. The maternal diet, obesity, and weight gain during pregnancy is a risk factor for bronchial asthma. Breastfeeding is protective against asthma. Can we prevent asthma? The development and persistence of asthma are driven by gene-environmental interactions, but there are certain measures that might reduce the incidence of asthma. One of these measures is avoid exposure to tobacco smoke in pregnancy and early life. Encourage vaginal delivery, and this is probably related to the exposure of the infant to the vaginal bacterial flora. Advice for breastfeeding for its general health benefits, and those who are breastfed less likely to develop asthma than others. And where possible, avoid use of paracetamol and antibiotics in the first year of life. What's about the pathology and pathogenesis? In the upper panel here is the normal mucosa in the airways. This is lined by pseudostratified ciliated columnar epithelium with a few goblet cells, very thin basement membrane. In asthmatic airways, you will see that there is hypertrophy of the goblet cells, and there is sloughing of the epithelial lining with a thick basement membrane. There is smooth muscle hypertrophy in the submucosa, and there are inflammatory cells, which are usually eosinophils. In this slide, in the left-hand side, those who have atopic asthma, if they are exposed to the allergen that they are sensitive to. The allergen will be presented by dendritic cells to the Th2 cells. The Th2 cells will produce different cytokines like interleukin-5 that will recruit eosinophils, interleukin-4 to stimulate these cells to produce IgE, and interleukin-13 to produce smooth muscle hypertrophy. And these contribute to the pathogenesis of asthma. In those who are non-atopic, if they are exposed to certain pollutants or tobacco smoke, that will be the chemicals in these substances will come into the innate lymphocyte cells, and that will produce interleukin-5 and interleukin-13. But usually they don't produce interleukin-4, so there is no IgE production. And these cytokines or interleukins that are produced will lead to degranulation of mast cells and production of various chemicals that lead to bronchospasm in the airways. How we diagnose asthma? As any other clinical problem, a history of characteristic symptoms, and we have to demonstrate evidence of reversible airway obstruction. As we said before, airway hyperresponsiveness is confirmed by a fall in FEV1 after exposure to methacholine or histamine or other non-specific irritants. But airway hyperresponsiveness is not a must to make a diagnosis of bronchial asthma. The diagnosis of asthma, from the history, the symptoms are important. If the patient has the classic symptoms of asthma, cough, dyspnea, and wheeze, especially if these symptoms are worse at night and early morning, and they vary in intensity over time, and if the symptoms are triggered by upper respiratory tract infections, viral infections, colds, exercise, or allergen exposure, or exposure to irritants, this is more likely to be asthma. If the patient has isolated cough, asthma is less likely, but still we can have asthma who present with cough only. If there's chronic sputum production, this is not a feature of asthma usually. So patients might have chronic sinusitis or bronchiectasis. If the patient has shortness of breath with headache, dizziness, and numbness, this is hyperventilation syndrome. This is usually seen in young females. If there is exercise-induced shortness of breath with stridor, this is not asthma, but this might suggest upper airway obstruction. What's about the physical examination? The physical exam in asthmatic patients may be normal, especially if their asthma is under control or they are in remission, because as we said, the symptoms vary with time and severity. But the most frequent finding is wheezing, especially on forced expiration. But wheezing alone is not enough to diagnose asthma because we can see wheezes in patients with COPD, other respiratory infections, or inhaled formaldehyde. The other feature is to demonstrate that there is variable airway obstruction or reversible airway obstruction. We have to do spirometry. By spirometry, we look into the FEV1, which is the forced expiratory volume in the first second of the vital capacity maneuver, and we look the ratio. Normally, the FEV1 over FVC ratio in normal people more than 0.75 up to 80%. In patients who have asthma and significant symptoms, the FEV1 is less than 70. The FEV1 over FVC ratio less than 0.7. And there is excessive bronchodilator reversibility. If we do spirometry, we check the FEV1, we give rapid acting inhaled beta-2 agonist, salbutamol, and we repeat the FEV1. If there is a change from the baseline in the FEV1 more than 12%, and this change associated with more than 200 mil absolute increment in the FEV1, this is what we call reversible airway obstruction. If we don't have spirometry, we can use the peak flow. We give the patient a peak flow, and he has to check his peak flow every morning and evening. And as you know, the pulmonary function is worse in the morning and better in the evening. If the variability in the peak flow more than 10%, this is suggestive of bronchial asthma. Or we give the patient, if he has classical symptoms and he has wheezes, but we don't have spirometry or peak flow, we give him controller medication for 4 weeks, and we see him again if he improved clinically, or if at the initial testing, if EV1 and peak flow we did not demonstrate reversibility. If they improve after 4 weeks of controller treatment, this is enough evidence to diagnose asthma. If the initial testing, the spirometry is negative, we can repeat it at other times, especially when the patient has symptoms, because during remission, he might have normal spirometry. This is on the left-hand side, the volume against time, but nowadays, most of the spirometers, they give the flow against the. Here, this is in our lab in King Abdullah Hospital. This is a normal spirometry. In the first column here is the predicted values, and these depend on the gender, the height, and the age of the person. Here, pre-treatment, it means that before giving the bronchodilator, we have to do 3 tests of spirometry, take the best one, then we give the short-acting beta-2 agonist, and repeat another 3 tests and take the best one. This is a normal spirometry, and you can see a normal flow volume. This is spirometry of a patient with asthma. You can see the blue line is the baseline, and the red after bronchodilator. You can see that there is improvement. If we look at the FEV1 over FVC ratio, it was 69 before giving the bronchodilator and became 80, and the FEV1 improved from 2.55 to 3.06. So there is 20% increment and about 510 ml. So this is a reversible airway obstruction consistent with asthma. This is the peak flow. This is a simple device. All what the patient needs to do is to take a deep breath and blow into this machine or machine as fast, as hard as possible. And you have a reading here, which is in liters per minute. Do we need to do other laboratory tests? Most of the time, probably we don't need to do any further tests, just the history and the spirometry. Chest X-ray usually is normal, but if the patient presents with symptoms of asthma and he's in the middle age, then we have to do a chest X-ray to look for other conditions like that might mimic asthma. For example, patients with heart failure, they have cough, they have shortness of breath, and even they have wheeze. Blood test, we might do the eosinophil count, especially in patients with severe asthma, because if there is eosinophilic inflammation or eosinophilia, this is a risk factor for exacerbation, and we have to intensify our treatment. The IgE level might check the level if the patient is not controlled, and we consider treatment with monoclonal antibodies. Skin test, this is to see what substances the patient is allergic to, so to advise him to avoid these substances. If we diagnose asthma, we have to manage, and the aim of the treatment is to control the patient's symptoms and reduce the risk of exacerbations and risk of fixed airway obstruction and the risk from medication side effects. To achieve these goals, we need the partnership between the patient and the healthcare providers. We have to tell the patient from the beginning that asthma is a chronic disease. In adults, usually it is lifelong. It might change with time. There is treatment. Majority of asthmatics can be controlled if they comply with the medications. We have 2 types of medication in asthma, the controllers and the relievers. The controllers are the inhaled corticosteroids. These are the most important and most potent. Leukotriene antagonists can be used as controllers, but they are inferior to inhaled corticosteroids. They have side effects like nausea, vomiting, headache, irritability, and recently the FDA added this warning about mental health adverse effects. Theophylline has some anti-inflammatory action, but this is usually used in very poor countries because it is a cheap drug. It has some effect. For example, 1 month supply of theophylline cost about 2 to 3 JDs, while inhaled corticosteroids varies from 10 to 15 JDs. Oral steroids as a last resort if the patient not controlled on other medications. When we talk about the treatment, we have 5 steps. We can add oral steroids, the minimum dose to control the patient's symptom in step 5. The reliever is the rapid-acting beta-2 agonist, whether short-acting like salbutamol or rapid and long-acting like formoterol. This slide showed the different inhaled corticosteroids and the relative potency and what we mean by low, medium, and high. All inhaled corticosteroids are effective if they are given in equipotent doses. So there is no one superior to the other. The inhaled medications came in 2 forms, either the metered dose inhaler, which contains a compressed gas. So this small, handy, and relatively cheap, these devices, but they are difficult to use. About 50% of patients, they are not using them properly. The first thing, you have to shake the canister to agitate the solution inside. You have to remove the cover, and the most critical step is to synchronize firing the canister and initiating slow, deep inhalation, and then hold the breath for 10 seconds. If the patient cannot use the metered dose inhaler properly, we can provide him with a spacer. This is for adults or children. Otherwise, we can advise him to use the powder-based devices like the Discus Turbohaler. You can go through the net and see how these devices are used. So if we diagnose the patient, we have to start the treatment, and we have 5 steps of treatment. Step 1, those who have infrequent symptoms, usually short-lived symptoms controlled by inhaled beta-2 agonist, not more than twice per week. There is no nocturnal symptoms. Either we give them short-acting beta-2 agonist when needed, but recently there is evidence that if we give them low-dose inhaled corticosteroid is better. If the patient is symptomatic, we go to step 2. We give low-dose inhaled corticosteroids, and the other choice is leukotriene receptor antagonist or low-dose theophylline. But the low-dose inhaled corticosteroids is superior to that. And always we give short-acting beta-2 agonist when needed, and that will give us a monitor whether the patient is controlled or not. In step, the patient is not controlled on medications of step 2, we go up. We increase the dose of inhaled corticosteroids, or we add LABA, long-acting beta-2 agonist. And long-acting beta-2 agonist, my low-dose inhaled corticosteroids is superior to medium doses of inhaled corticosteroids or adding the leukotriene antagonist. In step 4, we give medium or high inhaled corticosteroids and long-acting beta-2 agonist. If the patient is not controlled, we add tiotropium anticholinergic, or we use high-dose inhaled corticosteroids, and we can add leukotriene antagonist or theophylline. Because after step 4, the choices are very limited. Either we go for low-dose oral corticosteroids, and we should use the minimum dose and to control the patient's symptoms, or we refer the patient to specialist clinic where other choices might be available. The other choices like omalizumab, if the patient is a candidate, he has to be atopic with high IgE level. Or we can use interleukin-5 to block the eosinophil activity, or reslizumab or benralizumab, or the dupilumab, which act on interleukin-4 and interleukin-13. But these monoclonal antibodies, they are very expensive. They cost about 1,000 JD a month. Sometimes those who have very severe asthma and not controlled on all medications, we can consider bronchial thermoplasty. What we mean by bronchial thermoplasty, as we shown in the slides on the pathology, there is smooth muscle hypertrophy in the submucosa. So by radio frequency, we try to ablate the submucosal muscle hypertrophy, and that will give dilatation of the airways. This is still investigational in certain centers in the world. It has to be done through bronchoscopy, and we need to do 3 sessions. The first session, the bronchi of the right lower lobe. The second session, bronchi of the left lower lobe, and then the both upper lobes. And there are studies which showed that bronchial thermoplasty can help these patients when they have a severe asthma not responding to all the medications which we mentioned in the 5 steps of asthma. The patient, we have to see him and follow up usually after 4 to 6 weeks after starting treatment, and we have to ask the patient whether he has symptoms more than 2 times a week, whether he wake up at night from asthma, or he used the reliever more than 2 times per week, or any limitation of activity due to asthma. If the answer to all these questions is no, then he is well controlled. If the answer is yes to 1 or 2 of these questions, he is partly controlled. If 3 to 4, he is uncontrolled. How frequently we should see our asthma patient? Usually after starting treatment in 1 to 3 months. But when he is controlled, we can see him every 3 to 12 months. During pregnancy, we have to review these ladies every 4 to 6 weeks, because 1/3 of pregnant ladies who are asthmatic, their asthma might get worse. And if a patient was admitted for an exacerbation, we have to review him within 1 week, because the chances of recurrence of the exacerbation or relapse is high in the first days after the discharge from hospital. If the patient is under controlled, then we have to step up his treatment for at least 2 to 3 months. But before stepping up his treatment, we have to make sure that the patient is compliant with his medications and the inhalation technique is appropriate. Sometimes we advise patients to step up their treatment for a short period. For example, those who have common cold or viral infections or exposure to allergen, we ask them to increase the inhaled corticosteroids, double the dose for a few days until the cold or the viral infection is over. If the patient is well controlled, then he has to be maintained control for 3 months, and then we start stepping down treatment. And we reduce the dose of inhaled corticosteroids, and then if he is taking, for example, LABA, we might reduce that or stop it, but we shouldn't leave a patient who has asthma without inhaled corticosteroids, even a small dose daily. How we assess asthma severity? Nowadays, the asthma severity is assessed retrospectively. So this is assessed from the level of treatment required to control the patient symptoms. So after the patient being on a control medication for several months, we can see if he is controlled on a certain level, we categorize him whether he is having mild or moderate or severe. However, asthma is not a static disease. Someone who has a mild disease now, after a month, he might have a moderate or severe disease. So the categories of asthma severity: mild asthma when he is well controlled with step 1 or 2 of treatment. Moderate when he is well controlled with step 3. Severe if he requires step 4 or 5 medications, then he is having severe asthma. Those who have severe asthma and require step 4 or 5 for management, before adjusting the management, we have to make sure that he has asthma, because other diseases might mimic asthma. For example, COPD, upper airway dysfunction, or those who have recurrent respiratory infections. Then we look for comorbidities. Patients who have allergic rhinitis or sinusitis, if not treated, they will have similar symptoms with cough and shortness of breath. Obese people, we advise them to reduce weight. If they have symptoms of reflux, we have to give PPIs. If there is a question of obstructive sleep apnea, we have to do sleep study. And if he has sleep apnea, then we might put him on CPAP. And if there is psychological or psychiatric disorders, we have always to check the inhalation technique and adherence with the medications. And we have to investigate for persistent environmental exposure, especially if there is a question of occupational asthma. We have to take a detailed history and see whether there is any exposure to toxic substances or allergens. There are non-pharmacological interventions, for example, avoidance of tobacco smoke exposure. Unfortunately, many of our patients with asthma, they do smoke due to the high prevalence of smoking in Jordan. If they tried and failed, we can help them by prescribing them nicotine patches or nicotine receptor agonists. We advise them, encourage them to do physical activity, and we provide advice about exercise-induced bronchospasm. If they have exercise-induced bronchospasm, we prescribe them short-acting beta-2 agonist or before the exercise, or if they are using formoterol, they can take 1 puff before the exercise. If there is a question of occupational asthma, we have to look thoroughly into the occupational history and remove these patients from exposure to sensitizers. We advise them to avoid the medications that might worsen asthma, like non-specific or non-beta blockers or the NSAIDs. About 10 to 15% of asthma, they have what we call aspirin exacerbated respiratory disease. Their asthma gets worse if they took aspirin or other non-steroidal. Usually these patients, they are adult onset asthma. They have associated nasal polyps and eosinophilia. If there is any question of that, we advise them to stop taking aspirin and other non-steroidals. We look into the personal environment at home. If there is molds or dampness, remediation of these might help these patients. Those who are asthmatic and having allergic rhinitis, if they are allergic to house dust mite, we can advise them to take the sublingual immunotherapy, and usually it takes 2 to 3 years. It can help the rhinitis and sometimes helps the asthma in these patients. In our clinic, we should look for risk factors for those who have asthma and there is a risk of mortality. Which patients are at risk of mortality from asthma? Those who have history of near fatal asthma or who ever intubated and ventilated for bronchial asthma. Those who are hospitalized in the last year or visit the emergency room more than once. Those who are not using inhaled corticosteroids or poor adherence to the inhaled corticosteroids, they are at risk of death. And those who are currently using oral corticosteroids, and those who are requiring more than 1 canister per month of short-acting beta-2 agonist, and those who have never being given an asthma action plan. And if there is history of psychiatric diseases or psychological problems, and those who have confirmed food allergy. These patients, we should flag them and we should review them frequently, not every 3 or 4 months, probably every month we have to see these patients to stress on them to adhere to their medications because they are at risk of severe exacerbation and even death. What's the written asthma action plan? Any patient who has severe asthma, he should have a written action plan. The aim is to show the patient how to recognize and respond to worsening asthma. It should be individualized for each patient and the level of asthma control and according to health literacy. And this action plan based on the symptoms and pulmonary function, which is usually the peak expiratory flow rate. The action plan should include the usual medications the patient has, when and how to increase the reliever and controller medications, and when to start oral corticosteroids. And if all these measures failed, he should come to hospital and get admitted. Why? Because there are a lot of studies on this subject, and it has been shown that asthmatics, if they have a written action plan, it reduces the mortality and morbidity in these. Now we will talk about asthma exacerbations. Some people prefer to call it flare-up rather than exacerbation because exacerbation is frightening to the patient. What we mean by that, flare-up or exacerbation, is an acute or subacute worsening of the patient's symptoms with deterioration of pulmonary function, in spite the patient is compliant with his medications. The most common triggering factor for asthma flare-up is probably the upper respiratory tract viral infections, but exposure to allergens or severe stress can precipitate an exacerbation or flare-up. Usually these patients present to the emergency room. In the emergency room, the first thing to look for is there any features of life-threatening asthma. These are the features of life-threatening asthma: the drowsiness, confusion, and silent chest. What we mean by silent chest is that he has so severe airway obstruction and he is fatigued so that air cannot get in or out, so we don't hear any wheeze. If he has any of these features, this is life-threatening. We have to arrange a bed in the intensive care unit. Meanwhile, we start him on short-acting beta-2 agonist in the nebulized form and oxygen and prepare the patient for intubation. If he doesn't have any of these, we should see whether he has mild or moderate or severe disease. And those who have mild or moderate disease, their peak flow is above 50%, and usually they can talk in phrases. They prefer to sitting to lying, but they can lie. They are not agitated. The respiratory rate is increased, but did not reach more than 30, and the accessory muscles are not used, and the pulse rate less than 120, and the oxygen saturation on room air 90 to 95. The severe one, they have peak flow less than 50%, and they can talk in words. Any of these features is enough to call it severe, provided the peak flow is less than 50. The other features, for example, he preferred to sit and cannot lie flat. He is agitated, might be agitated, the respiratory rate more than 30, and he is using the accessory muscle and the oxygen saturation less than 90%. After the initial assessment, if we think that the patient has mild or moderate asthma flare-up, we start giving him nebulized beta-2 agonist. We can consider adding ipratropium because there is evidence that the effect is better when combining ipratropium with beta-2 agonist. We give them oxygen to keep their saturation above 93 and 95. We can give 2 to 3 nebulizations every 15 minutes, and review the patient and check his peak flow. If his peak flow is still low, did not reach 60 or 70% of predicted, we can consider adding oral corticosteroids because the corticosteroids will take time, usually hours, to start acting. If he has a severe asthma exacerbation, we give nebulized short-acting beta-2 agonist with ipratropium. We give oxygen. We give steroids either orally or intravenously because both are effective because the bioavailability of oral or IV corticosteroids is the same. And the dose of corticosteroids usually 1 milligram per kg methylpred or other equivalent corticosteroid. If he is not responding after 2-3 nebulization and after giving oral or IV corticosteroids, we consider giving 1 dose of magnesium sulfate 2 grams over half an hour, and some studies showed that it can be helpful and reduce the admission rate and improve the pulmonary function. High-dose inhaled corticosteroids might be tried in the emergency room. We give nebulized budesonide, but the oral or IV are more appropriate for severe. We review these patients and check the peak flow. If the peak flow, for example, in those who have mild or moderate exacerbation reach 60 to 80% of predicted, we step up the treatment of the patient. We give a short course of oral corticosteroids and discharge him home and review him in the clinic within 1 to 2 weeks. If he has a severe flare-up and still his peak flow is less than 60%, we can give them further nebulization, but we shouldn't keep the patient more than 4 hours in the emergency room. After 4 hours, if his peak flow is still less than 60%, we admit the patient to the hospital, we continue the nebulization, we continue the corticosteroids, and if there is any precipitating factor, we treat it. Normally, we don't give antibiotics to these patients because majority of these patients, they have viral infections. But if there is an evidence of bacterial infections, then we give antibiotics. If we admit these patients, usually they require about 7 to 10 days until their asthma is controlled. The first thing to improve in these patients is the patient well-being. He is feeling better, but he is still having wheezes if you listen to his chest, and the peak flow is still low. Then the wheeze will disappear, and the last thing to improve is the peak flow. If his peak flow goes back to normal, above 70% of his predicted, we try him on the home medications for 24 hours in the hospital. And the home medications should include oral prednisolone, inhaled corticosteroids, inhaled long-acting beta-2 agonist, inhaled short-acting beta-2 agonist, and early appointment in the clinic within 2 weeks. In the clinic, if we see the patient, we have to see them soon after discharge because the chances of relapse are higher during the early days after discharge from hospitals. This is an opportunity to review the patient medication and his illness to see whether the patient understands his illness well and whether he is compliant with his medications and encourage him to be compliant with the medications. We check his inhalation technique. If there is any modifiable risk factors like smoking, we advise him to quit smoking and check their inhaler technique. And if they don't have an asthma action plan, we provide them with an asthma action plan according to his disease and level of education. Nowadays, with the pandemic of COVID-19, asthma management during these days, we advise asthmatics to continue taking their asthma medications. Whatever medications they are taking to control their disease, they have to continue with them, particularly inhaled corticosteroids. And if they require oral corticosteroids, we advise them to continue. We have to make sure that all patients has a written action plan. Where possible, we should avoid use of nebulizers. We can use metered dose inhaler with spacers because the nebulizers can transmit the infection to other people and healthcare workers. We avoid doing spirometry in these patients who have confirmed or suspected COVID, again, because of the risk of transmitting infection. And we advise them to follow the infection control recommendations. If other aerosol generating procedures, if they require oxygen therapy or non-invasive ventilation or intubation, we have to follow the infection control recommendations. Thank you.